Hello, hello. Nice to see your faces. It's already Wednesday. It's already, what is that, day 4 for us. It flies by. I hope you're all doing well. I'm going to drop the notes in the chat, though they were also emailed to you. I did forget to put them on the Teachable today, so I'll do that after the call. All right, sending now. Just so we're all on the same page. So tonight we're going to review the SI joint tests. We're going to talk about the interventions that were shared. We're going to talk about SI joint pain. And then I'm going to invite you to the next round of the LTAP Level 1 course. Is there any specific questions that you have from the last 3-4 days that you want me to make sure that I get to? Obviously, as they come up, you can throw them in the chat and we'll have time at the end for questions too. But just, if there's any sort of burning questions in your head that you want to get off your chest, you can throw them in the chat or you can unmute yourself and ask them. Let me know. Just want to make sure that I am covering it all today since this is our last live call together. I know I've answered some questions in the chat or in the comments in the course, so hopefully you guys have had it there. So Cheryl just asked, does pregnancy change the assessment third trimester? For this, yes. I'm just gonna say yes, it does. Obviously a lot changes in the third trimester. I would say that in general, it may change things because of the relationship from the uterus to the SI joint. Now, it doesn't mean that you can't test it. It means that I would be a little less, what's the right word? Like I would be a little less trusting it as a good test. So we talked a little bit about in the first call, like what makes something a good test, and it is the ability for the test to be able to change. So since pregnancy, especially in the late trimesters when the baby's so big and like there's just not a whole lot of space, it potentially means that we just may have a situation that it's not going to change. Now, with that said, you don't know that, and everybody's different in their body in their pregnancy. So what I would do is I would go ahead and test it and see if it gives you any valuable information, and then just take it with a grain of salt. And then this is why having the rest of the LTAP is helpful, is because the rest of the LTAP can arrive at the same, not the same, a more specific conclusion than just the SI joint test. But the rest of the LTAP can work to find our protection pattern, or if there is no protection pattern, without needing the SI joint test. So, it's sort of one of those things, especially with the standing march test. Technically, there's not a contraindication for it. It just might not be a good test. So every patient's going to be different, and just keep that in the back of your mind. Another question was, how do I feel about doing the visceral and neural stuff on adolescents? I have no problem doing it. I do visceral work on babies, neural work on babies, all the way into older population. So it's not not a big issue. Obviously, you just more gentle for the younger babies, for the smaller people. And also you don't need to do treatment for as long. They respond to things a lot quicker. They have very better nervous systems. And so sometimes, like for an example, a treatment in a baby literally takes like seconds, versus treatment in an adult takes minutes, right? So the other question from Christina, have you seen test results change just by doing the vagus nerve parasympathetic system reset? Yep, exactly. That's how crazy. So like some of this too, and I saw some of the comments in the course from people saying like, oh my gosh, it blew my mind how doing this simple like basic exercise and then retesting the SI joint mobility, like how much it changed the SI joint. Like this should feel mind blowing because it is, especially when we consider like how much people argue about the reliability of the March test. And this is an example of inherently this test will never be reliable because it's a very visceral and nervous system driven joint. And so we can't expect it to act like every other orthopedic sort of joint test. So yes, it can change that easily. Yeah. Natasha said you described having one hand on L4 or L5. I was under the impression the test was done with the hand on the sacrum. So now I'm confused about how we are seeing SI movement with the hand on the lumbar segment. So the iliolumbar ligaments that go from L4 and L5 to the ilium are considered SI joint ligaments. So that is what we're testing. There's also some fibers that go from like the base of the sacrum, so like around S1 to that same area, sort of interdigitate with those iliolumbar ligaments. So your hand could be down onto the sacrum too. But yes, it's sort of counterintuitive, but it is the iliolumbar ligaments are part of the SI joint ligament complex. And yes. And L5S1 technically is even considered part of the SI joint. So it is all part of it. Another question, when the SI joint mobility doesn't change with the breath, but hypomobile side is opposite to patient's symptomatic side lower extremity. How do I explain this to patients? Why you are not treating the symptomatic side? I basically say there is in the body, there's not really such thing as right or left. Everything is connected. And I speak to the lower extremity, especially more than likely in that sense, I'm going to be treating somewhere that is relating to neurovascular bundles or neurovascular structures that need to slide and glide. So I explained to them that their lower extremity is a little bit like a steering wheel across the sacrum, across the lumbar spine. And as one side of the steering wheel comes down, the other side needs to glide up. So sometimes the issue is on the opposite side and I need it to help glide down or I need it to help glide up in order to free up the other side. And so I asked them to just be curious with me and see how one side affects the other side. And when you do that assessment and reassessment, they're usually like, whoa, that's so crazy that my right side was driving so much going on the left side. So exactly. Tiara said to confirm the LTAP test isn't the true Gillette's test based on the difference in the spinal landmark. Gillette's test, I mean, depending on where you learned it, it does say L4, L5, or S1. But the rest, so the way I learned Gillette's test in the manual articular of the spine class with the Burrell Institute, we can actually differentiate all of the SI joint ligaments, including the sacrotuberous and the sacrospinous ligaments, as well as the main sort of sacroiliac ligaments to figure out different fiber areas, but they are all attaching to each other, including the iliolumbar ligaments. They are all interdigitate. That's the picture I showed the cadaver picture I showed in the first live call. And so really you can assess any of them and get this result. It's just when your fingers are down lower in the sacrum, instead of the PSIS moving away, it might need to move closer. And so to keep it as simple as possible, we're keeping it on this landmark. Yep. April asks, do you still do OTAP movement prior to movement sessions that are not related to pain, but simply a training session? Yes, I still do, because if I am programming things, I want to know where I'm going to start to have the biggest effect on their session, their dynamic alignment, motor control, etc. Taylor asks, if someone has a neurological weakness, MS, stroke, TB, SCI, have you seen/heard of the test supine and our marches still being valid and showing differences results with your treatments, or is there a different retest test you typically utilize? As far as I know, my friends that work with these type of neurological clients still use the SI joint tests and get good results and use it as a test retest. They typically do the supine test, but they also could do a march test in a sideline position, like with a passive hip flexion as well. So any way you want to test that, if the nominate bone is able to move separate from the sacrum, should work all in the same. And again, this is that concept of like, the principle is that this joint is affected by this protective pattern in the viscera and the nervous system quite a bit with a strategic mobility. So whether it's active or passive test, the breath hold's going to change things neurologically around the joint. That means we will see that change in mobility. So you can use any SI joint test. Yeah. All right. All great questions. We'll go ahead and start. And then, if any other questions come up, we'll get to them too. Yeah, you guys are welcome. I'm happy that all of these are great questions, and I'm happy to always answer them. So I'll go ahead and share my screen. And adjust my chat box. All right. All right, so day 4, call 2. Like I said, we're going to review the assessment guidelines and interpretation. We're going to review treatment guidelines and options. We're going to talk about like what a session would look like. We're going to discuss SI joint pain and how that specifically plays into this, since it's an SI joint test. And we're going to talk about how to make this work even better. And invite you to the LTAP, and then we're going to go over some cases as well. So a big question I often get from a lot of people is how do I explain this to clients? And obviously I just answered like how I explain like when I'm working somewhere else, but the whole thing I explain to them, I'm like, hey, listen, so the way our musculoskeletal system works is its primary job is actually to protect us and protect the things that keep us alive, which are our organs. And our organs, I know we think of them in our head and our chest and our abdomen and our pelvis, but the organs also extend into our limbs, right? Our nerves and our vascular structures and our lymphatic structures, all of those things extend to our limbs. Those are like legs or arms to those important organs. So the nerves are like limbs of the central nervous system, and the vascular structures and then lymphatic structures are limbs to the heart and the lungs and the lymph, the spleen, those kind of things. Like, so the job of the musculoskeletal system is to keep those things safe. That's why some of those organs are inside the hard frames of our skeleton. Like, so oftentimes our mobility is limited, or our muscles are not turning on or turning off, right? They keep tight and stiff, or it's just hard to engage them in exercise, or even pain is created because the body, the musculoskeletal system, is really focused on protecting an organ. And when it is protecting that organ, it sort of goes into a little hug around it. And that totally changes our dynamic alignment throughout the entire body. And then I usually show them the thing with the shirt that I showed you all the other day. Like, okay, like imagine my lung is not happy because of hay fever, right? It's springtime. This is pretty common for my lung to, have a high load on it. And so the body kind of hugs it. And it's like the same thing as tying a knot in my shirt. And do you see how now everything is pulling in the direction over to my knot? So everything is arranging itself over the knot. So you can imagine the pull I would feel on my opposite hip, or the same side hip even, or the opposite shoulder, or even all the way down to the foot. Like if I was wearing a huge onesie, right, you would be able to feel that all the way down in your foot. I was like, so this evaluation is going to help me to figure out where your body is protecting, because I want to start treatment there so I can undo the knot and get you in the best dynamic alignment as possible and get the job of the musculoskeletal system to focus itself away from having to protect something and get back into the ability for it to help you move freely in your body. That's pretty much what I say. And then I'm like, does that sound good? And then I usually also reassure them, but don't worry. I understand your XYZ hurts, right? Your shoulder, your back, your knee, your foot. I understand you're coming to see me for your foot. And I'm going to assess your foot fully with my orthopedic assessment as well. And we're going to figure out all the things that are going on with your foot. Once I have that list, we're going to treat where the body wants me to treat. And then we're going to reassess because we want to see how all those orthopedic things around your foot change. And then we're going to do that a couple times. And eventually I'm going to get this list of orthopedic things affected around your foot and why your foot hurts. And it's going to narrow it down for me and really allow us to get super specific on what exactly your foot actually needs. So that's how I explain it to them, just as I explain it to you all. So in review, we're doing the standing march test. So we're looking at single leg hip flexion, observing dissociated movement of the SI joint between the innominate bone, right? This os coxa, innominate, and the sacrum. And the way we're doing it, right, is an orthopedic test used with osteopathic principles, which is the principle of inhibition. We're using the breath hold as our inhibition test. We're going to check it without the osteopathic principle of inhibition, and we're going to check it with and see how it changes. Normal would be with regular breathing, the innominate bone posteriorly rotates and the sacrum maintains its position. Hypomobile is the innominate bone doesn't move into a posterior rotation, or both the sacrum and the innominate bone moves into posterior rotation. And then often opposite side will rotate as well, okay? So how do we interpret this? We do that test again, especially if one side or both sides is not moving, and we have them do it with a breath hold. And if that breath hold changes the hypomobility, that is directing us to the viscera and or the central nervous system as the primary area for that protection pattern, driving that protection pattern. If the breath hold does not change the hypomobility, we start treatment on the same side of the lower extremity. If both sides of the SI joint are normal, right, they both move, then that is the dealer's choice. That is the clinician or the patient's area of choice is fine to do the treatment. So if their foot hurts, that's why they're in here, and both SI joints move, no problem, then go ahead and start at their foot. More than likely, whatever you do around their foot, the assessment, still do a clinical assessment, figure it out, right? But then once you get all of your ideas from your clinical assessment, like just start treating it as normal. And you can feel comfortable that they're likely going to get really good results because they're already in a resilient nervous system state that is ready and open for treatment and to participate in the healing, right? To be an active self-healing capabilities. So, and that's why I refer to this test, this SI joint mobility locator test, as a traffic cop. It's basically giving us three options. Either you go to the viscera and the central nervous system, the same side, lower extremity of the SI joint that's hypomobile, which could include the SI joint itself. So I would encourage you to not go there first, or go anywhere you want, dealer's choice. So guidelines, my assessment guidelines for a clinician is sort of what I just explained it to you. I like to actually start with the LTAP, or in this case, just the results sheet code, just the SI joint mobility locator test, before I actually ask them what's going on. The more unbiased I can be about what hurts, the clearer the picture will be for me, because I'm not trying to like make them fit into my idea of something. So ideally, I don't like knowing what they're coming for. With that said, sometimes I still ask some qualifying questions to make sure it's okay to push on things. If they have like significant low back pain and SI joint pain, and or like if they look like they're uncomfortable standing, then you can go ahead and start with a history, so you can have a better idea of like what a more appropriate testing position would be. But for the most part, everyone's going to like, fairly easily walk through the door to your treatment session or whatever you're going to do. So if you still want to start with a subjective history, fine. If you just want to make sure, you check the intake forms on their medical history, to check some like red flags like osteoporosis, or, for the rest of the LTAP, we talk about like pacemakers and things like that, then that's fine too. But the more unbiased you can be about what's going on when you're doing this assessment, the better it is. So they come in, I do the SI joint mobility locator test. Then once I know which direction the traffic cop is directing me, then I sit down with them and I'm like, okay, so what's going on? With that said, sometimes if it's their first session, then I start with that spiel that I just told you. I'm like, hey, I do things a little differently around here. I'm combining orthopedic and osteopathic assessment, and it looks like this. And we're going to start with this test, and this is what this test tells me, and this is why it's important to look at. And then I do the test, and then I'm like, okay, now we can have a conversation about what brings you in today. So after I take that subjective history, then I know what I need to do from assessing an orthopedic test. This is your current evaluation or assessment. It might look like provocative tests. It might look like joint mobility tests. It might look like strength tests or motor control, movement patterns, all of the things, whatever you do that then. And once you have all that information gathered, then you treat where the body directed you, and then you reassess those things. And we'll talk about treatment guidelines in a second, but for right now, this is assessment guidelines. So I'm assessing the SI joint locator test. I'm getting the information from the traffic cop. I'm doing a subjective history, and then I'm doing my clinical evaluation. If you're a movement practitioner, right? So you're not doing a clinical evaluation, but you're doing a movement session with them, it's going to have some similarity to it, right? They're going to come in and you're going to start with the SI joint mobility locator test, because still you want to know, do I want to start their movement session in the head, neck, and trunk? Or can I just start with legs? Or, where do I start? Then you can take a subjective history if appropriate, right? Like if it's your first session with them, or even if it's just, if somebody you see every day, you can be like, hey, how are you feeling today? What's going on? Just like you would do in a normal session, a normal situation. And then you're going to assess some sort of baseline movement. And it can be as simple as a squat, or standing trunk rotation, seated trunk rotation, or a forward fold. It can be anything you want, right? But make sure you're assessing something. If you're not assessing and seeing where you're starting, then you're never going to see how things change. It's impossible to see change if you've never done a baseline. If you're a massage therapist, same kind of scenario. Your patient comes in, you're going to explain what's going to happen. And then you're going to do the SI joint test. If we're doing the standing march test, it's before they get unclothed and under the blankets, right? You're going to be like, hey, before you lay down, let me just check something real quick. And you're going to do it regular with the breath hold. You're going to know where the traffic cop is directing you. And then you can be like, what are you coming in for today? Are you looking for a relaxing massage? Are you looking for like a specific body part hurts or whatever, right? You're going to ask them why they're there. And then you can have them go ahead and, get under the covers when you come back in, do some sort of assessment. It can be a movement even before they lay down. It can be just a general trigger points, some common trigger points. It can be simple passive range of motion of the neck, passive range of motion of the arms or the legs. You choose whatever you normally do. But this is sort of one thing that a lot of massage therapists probably are not doing some sort of assessment, but it can be really quick. And you can even ask the patient to do it themselves before you lay down, within them still standing. So you have something to check at the end. So then the treatments. So those were the assessment guidelines. So now we can talk about treatment guidelines. So treatment guidelines, I like to do 3 rounds of this testing, whether I'm just doing the SI joint test, like in the results cheat code course, or I'm doing the full LTAP, I'm doing 3 rounds of it. Because once you, and this is something that people sort of sometimes have a hard concept to understand at first, is like, if the SI joint doesn't move, they hold their breath and it moves. So then you pick an exercise, you do all the rest of the assessments and you're like, okay, I'm going to start in the central nervous system or the viscera. And you pick one of the exercises you liked or whatever treatment you like to do. Maybe you picked a basic exercise and then you reassessed. And now the SI joint, maybe the SI joint on that side that was hypomobile now moves, but now the other one doesn't move. And so you don't panic. You just understand that now the SI joint is like is how the body is communicating with us. It doesn't mean that you did something wrong or that wasn't the right exercise. It just means that there's another protective pattern going on somewhere, especially if it changes with the breath hold. But even if it didn't change with the breath hold, it means the protective pattern is now in the leg on the opposite side. So we go there. It's not like if one time around, if it doesn't normalize and make both move, this is not a problem. This is not a problem, because the way our body works in terms of protection patterns is there's many protection patterns all around our body at all times. What makes us really amazing is our ability to compensate. When we lose the ability to compensate, when our sort of cup of compensation, I call it, or like when we are like out of, let's say we have like a certain amount of protection patterns we can use, right? It's like lives in a video game. If we have used all of those protection pattern lives, then the body is like, I can't compensate anymore. This is when we lose the ability to compensate. This is when things hurt. This is when things get injured. This is when we move, like we have movement dysfunctions or whatever, when we lose the body ability to compensate. So when we do this test and the first round, we see the most important protection pattern at that moment in time. And then we do a little something and we help the body get out of that protection pattern. It's like we're peeling off layers of an onion. So now we are exposed with the next layer of protection pattern. And then we do it again and we get the next layer of protection pattern. And maybe within those 3 layers, we came to a moment in the body where the body was like, you know what, we're good. We're at a balance point. We're at like homeostasis. Thank you for helping me with that protection pattern. We're good now. We're not in a major protective pattern. We're in a state where we're trying to like reintegrate things. And so then you get to do whatever you want. But maybe you never get that. Maybe you just stay in a protective pattern. It doesn't mean that you didn't do a good job. It doesn't mean that you were wrong. It just means that there's more to do. But 3 rounds of protection patterns is a lot for the brain. And that is what we're dealing with, is we're basically trying to bring attention to the we're trying to direct the brain's attention to a certain body part to remind them, hey, remember when you got overwhelmed with all the things you had to compensate for? And instead of dealing with this allergy in your lung, you just went into a protection pattern around it. Now, I'm letting you know, I'm helping you create a little space there, but if you could go in and do your magical self-healing thing and help us out, we'll be good, right? So we only want to do these 3 rounds of specific treatment like this because we don't want to overwhelm the body with too much to think about. So it might be, though, you do 1 round, right? And then the body shows you like, oh, both sides of the SI joint move, like you're good to go. There was only 1 protection pattern that the body felt like it needed help with at that time, right? Sometimes it's 1, sometimes it's 3, sometimes it's 2. That's why we check, right? So the destination is not necessarily always going to be 2 mobile SI joints. That would be great, but sometimes it doesn't happen. But by unlayering these protection patterns, you're going to make people feel better. All right? So the treatment guidelines would be 3 rounds max, 1 round minimum. First round, same thing. Start where the body directs you, right? Visceral or central nervous system, hypomobile leg, or area of injury or complaint. And then you reassess. Not only do you reassess the SI joint, you reassess all the orthopedic tests or movements of interest. And then you do the second round. Treat where directed by the SI joint. Reassess. Reassess orthopedic tests. Okay? So we're constantly assessing, reassessing, assessing, reassessing, right? So by the 3rd round, same thing, you're going to treat where the traffic cop direct you, and then you're going to reassess. Even though you know you're not going to do another protective layer, you want to know what happened, right? Reassess the SI joint, and then reassess all the orthopedic stuff. And then at that point, you're just going to treat anywhere else per your area of interest as a clinician or the patient. What you want to make sure you do is touch or treat the area that the patient is complaining about, right? You don't want the patient to think that you don't listen to them. So you want to make sure you do a little something on whatever they're complaining about. But the cool thing is you should be every round reassessing that area anyways. And most patients don't know the difference between assessment and treatment. And so you're touching that area a lot throughout the session, right? And you're also showing them as it changes, right? But sometimes even when an athlete sees their, like if they have foot pain and they see the mobility change and they see the function change and they don't have pain anymore, they're still like, well, can you massage a little bit on like this part of my foot? Right? If that's what they really wanted, then go ahead and do that. You're not going to hurt it at that point, right? So you definitely want to make sure you're still addressing where the person is complaining about, but you should be doing that through assessment and reassessment the entire session. So the treatment options that I provided you in the teachable platform. Remember, these are not the only things you can do. These were just some suggestions. Because if I didn't provide suggestions, y'all would have been mad at me. Even though from the get-go, I have told you that this is an assessment course. And that the core belief we all agreed upon in the beginning, right? The set of rules we were going on is that the tool or the technique that you used doesn't matter as much as being in the right spot. So remember, all the things that you already know how to do work well, okay? So in general, when it comes to the visceral or the central nervous system, breathing exercises are good, self-massage exercises are good, neurology-based exercises like eye and vestibular work are good, or cerebellar work. Any sort of neural resets, so trigeminal nerve massage, hair pulling, scalp pulling, ear rubbing, tongue mobility, all of these things are really great. And then spine mobility is a really good one too. All of you Pilates instructors, Like every time you do a segmental movement, a segmental roll down, a segmental cat-cow, all of those things, you're treating the central nervous system because you're affecting the container of the central nervous system, right? So this is a reminder, you know tools already. The 5 things I gave you in the teachable are just like giving you some new things, but those are not the end all be all, right? So use the tools that you already know and the ones that you love. You love them because you already know they get good results, right? You're just now being a little bit smarter with when and where to use them, okay? And then with the lower extremity of the hypomobile SI joint, think bigger than just the SI joint. We talked about it in the first call, but it's typically a result of still something going on in the lower extremity being reflected via the nerves to the SI joint. So it's still a strategic hypomobility the majority of the time. So in my experience, I would clear all of the lower extremity stuff before I go to the SI joint. Because too, let's say it was the SI joint ligaments that are like stiff and need some mobilization. Those ligaments are going to be easier to mobilize when you give some reflexive information via those 5 nerves that we talked about the other day, and we'll talk about again. But the obturator nerve, the cluneal nerves, obturator nerve, cluneal nerves, superior gluteal nerve, nerve to the quadratus lumborum, quadratus femoris, and the lumbosacral trunk. All of those, when we give more information to them, when we stimulate them, it has a reflexive effect on the SI joint ligaments. Then when we go in and mobilize, we're going to get more out of that. It's going to be easier for us. We're not going to have to use so much force. But most of the time, you're going to do stuff in the leg, and then you're going to recheck that SI joint, and you're going to be like, wow, that really changed that SI joint. So what's the benefit of visceral mobility exercises? So one of the exercises I gave you was like embodying like liver mobility and doing like a little liver focused compression and breath. The cool thing about the visceral exercises is it's also a neural exercise because of the influence from the vagus nerve, the phrenic nerve, and the pelvic splanchnic nerves. They all have an influence on the central nervous system. So it's kind of high bang for your buck to pick visceral stuff because you get a little bit of effect of both. The benefits of neural resets are sort of similar to that. So nervous system relaxation and decreased tension on the cranial meninges. Whenever we relax our nervous system, we make our organs happy too, because a lot of them are related to digestion. And so it will affect the viscera. So it's often these are like a two-way street. The benefit of spinal mobility, right? I already said it. The spinal mobility stuff is affecting the container of the central nervous system. So it's affecting the central nervous system via the spinal dura and reflexively by the viscera because of the viscerosomatic reflexes. So as you're moving that spinal container, you're also affecting the nerve roots at every level of the spine. And those nerve roots then go to the organs themselves in the parietal peritoneum and the thoracic or pleural peritoneum and innervates those two. So it's going to have an effect on the viscera. So spinal mobility, really good to do. And you can get really specific. So we talk about in the LTAP Level 1 course, because in that course, we learn once we know it's visceral or central nervous system, we dial it in and get specific to what organ is it? Is it the lungs or is it the liver? Is it the kidney? Is it the small intestine? We figure out what organ it is because the more specific we can get with our assessment means the more precise we can get with our treatment. And the viscerosomatic reflexes levels allows us to get really specific with our spinal movement, right? So if someone's body is protecting, the liver, I might want to do some very specific targeted movement around T7 to T9. or even at C4, C3, 4, and 5, where the phrenic nerve comes out because of the relationship there. So understanding these connections allows us to get really specific with that spinal movement, because spinal mobility treats the central nervous system and the viscera reflexively, right? So we're getting 2 bangs for our buck there. So the treatment options I provided in the teachable, I did sideline visceral massage with the Corgis ball, liver-focused embodiment during thoracolumbar rotation. I'd also put in restoring upper thoracic flexion for the mediastinum, which is part of the thorax. The obturator nerve glide could be used for the lower extremity or for the viscera, because the obturator nerve innervates the parietal peritoneum. The neural resets, everyone's favorite, the best basic exercise by Stanley Rosenberg. Scalp massage, real easy to do. The cannonball massage, it's more, it's also kind of visceral and neural. It's a little bit of both. And then the trigeminal nerve glide, which really affects the cranial dura quite a bit. The options I put in for treatment of the lower extremity was obturator nerve, again, common peroneal nerve glide, and then the lateral ankle tilt. A lateral ankle tilt is just simply a mobility for the fibula, and that's going to affect the common peroneal and deep peroneal nerve. Common peroneal and deep peroneal nerve. So let's walk through some treatment scenarios. So person comes in, we start with the SI joint mobility locator test. And let's say that they have left SI hypomobility that changes with the breath hold. Oh, did I write? Oh, no, let's ignore what I just said. I forgot I wrote it out on the next slide. So the person comes in, we may or may not know that it's the right knee pain patient. They come in, we do their SI joint mobility locator test, and then we ask them what's going on. They say right knee pain, and then we assess some movement or some trigger points or do a clinical evaluation on them. So here's the scenario. They come in, the SI joint mobility locator test was hypomobile on the right, and it changed, it improved with the breath hold. So that directed us to visceral or central nervous system. Before we did treatment to the viscera or the central nervous system, we paused and we talked to them. Hey, I have right knee pain. Oh, okay, interesting. I'm gonna go ahead and assess what I would normally do for someone with knee pain. I looked at ankle dorsiflexion. I looked at prone knee bend. I looked at a movement. I picked a lunge. And I looked at passive hip flexion. So real basic stuff. They had limited ankle dorsiflexion on the right, limited prone knee bend on the right, pain with the right leg back on a lunge, and then their left hip flexion was limited. So what did I choose for treatment? The body was directing me to central nervous system or visceral, so I chose sideline visceral self-massage. So we did sideline visceral self-massage with the Corgis ball. And then once we were done with that, we retested everything. So retested the SI joint mobility locator test. It was now hypomobile on the left, and this time it didn't change with the breath hold. So that's directing me to the same side, lower extremity on the side of the hypomobility. So the left side. So this is that kind of scenario we talked about at the beginning with the question. It's right knee pain, but its body is telling me to go to the left side. But before I treat that left side, I need to reassess the right side orthopedic stuff related to the right knee, because I'm still curious, how did that visceral massage change things? I look at their ankle dorsiflexion and look at that, it improved. Their right prone knee bend is still pretty limited, and I forgot to retest the lunge. This sometimes happens, especially when it's a movement off the table. But I chose treatment to the left common peroneal nerve, did the peroneal nerve glide, and then retested. It's a quick thing. It's like 6 reps. Doesn't take very long. Retested. SI joint mobility locator test now moved on both sides. Great. Super excited. That means if I do need to do more treatment, I can do wherever I want. But let's see what's left over on the right side of their body, the right knee, to see what else is going on with this knee. Retested what was left of the orthopedic thing, so which was the prone knee bend, and voila, prone knee bend improved. Left hip flexion improved, and then this time I remembered to test the lunge, and no pain with the knee, right? So it's like, really don't have to touch their knee at all, but if the athlete or the person still feels like you need to do something around their knee, rub their knee a little bit, do something super generic, and you're good, because you've already eliminated their pain and improved all their orthopedic things. Or just go do exercises, right? Whatever you feel like they need, but that's a typical, well, I don't want to say typical because everybody's different in how they present and go through this. It's a very specific sequence to this person. But that's how it can be as we unlayer it. So this time, right foot pain. So same thing, we're going to go SI joint mobility locator assessment. It was hypomobile on the left. It improved with breath hold. So directing us to visceral central nervous system. Check all my orthopedic things. They had limited right ankle dorsiflexion. Oh, they said they had right foot pain. So I'm like, okay, let's look at some orthopedics. They had limited right ankle dorsiflexion. They had limited right hip adduction and limited left hip flexion. Okay, interesting. I picked sideline visceral self-massage again as the treatment. And then we retest. We retest the SI joint. This time it was hypomobile on the left again and improved with the breath hold again. So this is a spot that you could easily find yourself get frustrated, right? You're like, fuck, like it didn't change. But that's why we reassess the orthopedics. If we only reassess the SI joint, we don't have a clear picture of if that treatment was effective or not. We have to reassess the orthopedics. And so what did happen when I reassessed the orthopedics? The left hip flexion improved, and the right ankle dorsiflexion and the right hip adduction still were limited, but the left one improved. So does it mean I did something wrong? No, I got a good outcome. It just means that the next protective pattern is still a visceral or a central nervous system one. No big deal. But this time I was like, okay, I did some viscera, got a change, but not a ton. So let's pick central nervous system this time. So I treated did the basic exercise and the right accessory nerve glide. And then retested. Retest, the SI joint mobility locator test was now hypomobile on the right, so the other side. And this time it did not change with the breath hold. So it directed me to the right lower extremity, which is like, feels like a win when you are dealing with the right lower extremity issue, like in the foot. But before I get excited about treating the foot, I want to reassess all the orthopedics. I check it out, and the right hip adduction was improved, but the right ankle is still limited in dorsiflexion. So what did I choose to do? I chose to do a mobilization to the right ankle for dorsiflexion. Boom, took me right to the spot, okay? One last case, sort of, hopefully this is helping you kind of like see how it works. Person comes in, we start with the SI joint mobility locator test, see where the body's directing us. Hypomobile on the right and improved with the breath hold. So the body's telling us there's a protection pattern in the viscera or the central nervous system. I'm like, okay, great. What brings you in? They're like, I got left-sided sciatica. Okay, let me do an evaluation on you. Their left hip flexion is limited, their left hip external rotation is limited, and their right prone knee bend is limited. I'm like, okay, I've got the information I need. Treatment, the body directed me to the viscera of the nervous system, so I'm going to start with the liver because I remember from Anna's podcast or the visceral referral cheat sheet that the liver and left sciatica go hand in hand. And so I'm like, yep, let's start with the liver, visceral self-massage with the cortisol and the embodied rotation. We retest. In the second round, both SI joint mobility locator tests move. Great. So the body's like, oh, cool, I'm not protecting something anymore. So I'm not finished. I reassess, right? I'm like, okay, now how's your left sciatica? And all the orthopedic things. So I'm like, okay, look at that. Your hip flexion improved on the left. Your external rotation improved on the left. Your sciatica pain is gone. Great. And also, you don't have any limitation on your right prone knee bend. Awesome. So now what do? I still have 40 minutes left in the session with the person. I'm like, okay, great. Do what you would normally do for a patient like this. They've probably been afraid to bend over for a while because of their sciatica. So I'm going to do movement exercises to decrease their fear of bending over. I'm going to do some breathing exercises and maybe some thoracic rotation to reinforce that movement around the liver and that relationship between the liver and the sciatica and the lower extremity. At this point, you can do whatever you want. So it's like, don't forget how you would normally treat someone, right? This test is just sort of helping you figure out where to go. It's not replacing your whole plan of attack. What you do, right? We already agreed upon in the beginning of the first call. You already get good results. We're just trying to help you get even better results. And you get better results by letting the body help guide you on this wonderful, unique sequence that is specific to the patient and what they need. So we'll do one for the upper extremity because this is always a common question of like, what about the upper extremity? Do we still use the SI joint test? Yes, because the SI joint test is reflecting the whole body's protection pattern. So they come in, SI joint locator test, hypomobile on the right, it improved with breath hold. I'm like, okay, Sally, what do you come in for? She's like, my left shoulder hurts. Okay, great. Let's look at your left shoulder and all the orthopedic stuff. I don't know about you, but when somebody comes with a shoulder problem, I still look at their hips. So look at their hips. Limited right hip flexion, limited left prone knee bend. Left shoulder flexion limited and it's painful. And then decreased glenohumeral joint internal rotation. The traffic cop was directing me to the viscera and the central nervous system. So I go right to prone thoracic curve restoration and breathing exercises. In my experience, shoulder pains really need to improve thoracic mobility, thoracic curve. So the shoulder blade works better with the curve, but also like pick whatever you want. This is why I picked thoracic curve restoration breathing. Then I retest. When I retest, SI joint mobility locator test was hypomobile on the right still. This time it did not change with the breath hold. So now it's directing me to the right lower extremity for a left shoulder pain patient. So I'm going to reassess all the orthopedics I did. Look at that. The left hip prone knee bend improved. Left shoulder flexion improved and their pain decreased. And they had decreased they still had decreased left glenohumeral joint internal rotation. Okay, cool. Body's directing me to the lower extremity of the right leg. I did treatment to the right deep hip rotators. And then I retested. This time, SI joint mobility test, both sides moved. Great. Retest the orthopedics, see what's left over in the shoulder. Retested the shoulder internal rotation. It was improved. Right hip flexion was improved. And so now I get to clear up any lasting pain or shoulder function, or I can just go into shoulder exercises if that's what they need, right? Before I move on to some general questions about the tests, I mean, I know there were some questions about these cases in the chat, so I'm gonna go back to the chat. Cheryl asks, is it typical for a client to return to the protective pattern after treatment? It can be, but also it can't. It sort of just depends on what's going on. So if it's a functional issue, so function and structure are very much intimately connected. So let's talk about the liver. So if someone is having like an overloaded liver due to allergies. So again, this is springtime. This is pretty common. Our liver and our lungs get pretty overloaded dealing with the toxins from the pollens and the allergens in the air. Okay. So that's a functional thing. But by treating the container, the structure around that organ, we allow it more space, we allow it its mobility to move, the function can improve because mobility of the organ is necessary for motility, which is the expansion and the contraction of the cells, to be optimal. And that motility is improvement for the vitality of the organ. And vitality of the organ is how well is the organ functioning. So by doing a container thing, I improve the function. But sometimes the function is so diminished or so taxed that they need some functional support too. So in this case, I can do all the low liver mobility stuff in the world, and it still might not overcome this functional load. So that would be a scenario where you do the treatment, you come back in, and they're protecting their liver again. It's like, how many times do I have to keep doing the same thing before I realize I need something else? So in that case, that's might be when you bring in different practitioners to help you, right? You might be like, well, it's around their liver and I'm not trained in visceral manipulation. So maybe I refer them to a visceral manipulation person to get a more specific and precise treatment, because the more specific and precise treatment, the better the effect. Or maybe I feel like, yeah, they've got really bad allergies and they need to go see the doctor for some sort of functional support around the liver, right? Whether it be like herbs or medicine or, whatever, right? Dandelion tea or like whatever, that's not my world. I'm not a functional medicine doctor, but like a realization that there is a functional thing. So that would be if a protection pattern comes back over and over. Or maybe it's a scenario that you need to ask some red flag questions, like what's going on? Like, do I need to refer you to a doctor? Like, right? Because if somebody has like a disease or cancer or something like this, body's going to go back and protect that area, right? That was the scenario we talked about with my mom. Another example of this is I had a patient with a ton of fibroids, and her tests were directing me to her uterus, and I was doing treatment, and sometimes that treatment actually make her feel worse. But my assessment was always bringing me back to this protection pattern around there. So that should have been a like light bulb for me to be like, something else is going on here. Maybe I need to refer her to somebody, right? For more in depth, right? So that would be a scenario of like a repetitive protection pattern. But typically when somebody has a protection pattern, I work on it once and it's good for a little while, right? Like I had an athlete the other day, he had a protection pattern around his central nervous system and then his bladder, and we did the treatment and things got better. And then I've evaluated him a few days since then and he's been good. Like it hasn't come up again. So that's more typical of what I see. Hazel asked, in the client case with the foot and ankle pain, what led you to treat with an accessory nerve glide? So the accessory nerve glide, I use as a visceral nerve glide to affect the phrenic nerve, because the phrenic nerve is a sensory nerve to the upper part of the abdomen. And the phrenic nerve and the accessory nerve share nerve roots. And it's easier to do a nerve glide to the accessory nerve than it is to the phrenic nerve based on the anatomy of the nerve. So that's why I did it. April asks, are you testing right hip flexion supine or standing? I usually test it in supine. I do passive hip flexion, but it doesn't matter. Those are just my orthopedic tests. You can test it in any way you want. Those were just examples of like some orthopedic assessments that I gathered. Cool. All right. Moving on. Oops, let me move my chat box. So, big common question I get a lot. What happens if both sides are hypomobile? What should I do? Well, if both sides don't move, still move forward with the next part of the assessment, which is do a breath hold. And when you do a breath hold, does it change? I said bilateral hypomobility can happen. However, it's likely one side has movement, but it's very limited. Perhaps you cannot feel, but either way, one side's not moving. So do a breath hold and see if it's changed, right? This is why practice is needed to trust your hands and the subtlety of things. In the rare case that you still have two similar hypomobile joints, do treatment on the side of the diminished pulse of the posterior tibialis pulse. This is actually part of the rest of the LTAP number 5 test, right? Or you need to ask them questions about, have they ever been diagnosed with like SI joint arthritis, or do they have an SI joint fusion, or right? You need to question, like, is there something wrong with the test? If there's something wrong with the test, if it's not a good test, then you can move on to the rest of the LTAP if you have that skill. So a little bit about SI joint pain. I don't know why it goes right into this. Funny. So SI joint pain. So inevitably, this question comes up because we're doing an SI joint mobility test. And so a lot of people are like, oh, this is great for my SI joint patients. Again, reminder, we're using the SI joint locator test as a full body assessment of a protection pattern. We agreed upon this in call 1, how the SI joint was connected to everything, influenced by everything, and like a transfer station for energy in locomotion, right? And so this is why we agreed that it's a good whole body assessment. Okay. So, oh, you guys are good? You can hear me still? Okay. Sorry about that. All right. So that's the first thing. This assessment is not about assessing for SI joint pain, period. With that said, it can be very helpful in us in guiding our treatment, even of SI joint pain. We talked about in call 1 how pain doesn't influence our test. Pain should not influence our mobility test unless it looks like they're in so much pain from the protective pattern around the SI point that it's no longer a good test. You can't see a change, right? Now, if the SI joint mobility test can still provide information of change despite their pain, we want to make sure that we do it because it could be helpful in sort of figuring out what their SI joint pain is coming from. But when it comes to true SI joint pain and diagnosing SI joint dysfunction or SI joint instability or SI joint like pain diagnosis for a doctor, you actually need a cluster of tests that reproduce pain, right? So again, do you see the difference between the SI joint mobility locator test and a pain provocation test? One relies on the reproduction of pain. One doesn't care about pain, only mobility, okay? So the cluster of tests that we use, the cluster of tests that we use traditionally in the world of rehabilitation for SI joint pain provocation tests to prove that someone's pain generator is coming from the SI joint. There's 2 clusters, one called the cluster of van der Waals and one called the cluster of Lisette. These are designed to help clinical decision making around proving that the pain generator is the SI joint. This is important if somebody is thinking about doing an injection for their pain, okay? So each of the clusters has a different amount of tests, but basically one of them has 5 tests and one of them has 6 tests. And in order for it to be indicative of the SI joint being the pain generator, 2 to 4 or 3 or more of them need to be positive for pain provocation. So if all 5 to 6 tests are negative, this is a strong indication that the SI joint is not an indicator of being the pain generator. But if 3 or more are positive, then it could be the SI joint, though it's still not a solid always the SI joint. This is what makes the SI joint pain diagnosis very challenging. So no single test or cluster has been correlated with post-injection pain relief, right? This is why they use a cluster of tests. So the tests used are the thigh thrust test, Gaislin's test, Faber's test, also called Patrick's test or Patrick's sign, the distraction test or compression test, or the sacral thrust. The distraction test and the compression test are both held and sustained for like 30 seconds to try to provoke pain, whereas the other ones are just single tests. The thigh thrust and the sacral thrust both involve a little bit higher velocity forces to elicit pain at the joint. So again, not any of those single tests are being positive or indicative of the SI joint being the pain generator, but it has to be 2 to 4 for one cluster or 3 or more for the other cluster. But if all 5 or 6 of them are negative, then it is a strong indicator of that is not painful. The gold standard in diagnosing SI joint as the pain generator remains a invasive diagnostic of doing an injection in the SI joint itself to see if it relieves pain. Though also some studies have shown that can be even unreliable in itself, right? So if this feels a little frustrating, then it makes sense because it's like, this is why the SI joint pain can be tough to treat because it's tough to diagnose. But the SI joint mobility locator test, that's part of the LTAP, actually should help you out when you have these patients because it's going to direct us where things are actually coming from. The information about these pre-vacation tests, if you want to learn more, Physiopedia has a great blog on all of it, so I highly recommend reading that. They also link videos of how to do each test. So when we look at SI joint pain patterns, they should make sense to you now, knowing about the nerves that innervate the SI joint. The pain patterns of SI joint pain follows the nerves that innervate the joint or provide sensation to the area. This can be helpful. It can give you some information on what's being irritated, but it's still not conclusive. These joints in areas have a lot of innervation, right? The SI joint has a lot of innervation, which is why pain is so common and pain is so, I don't know if the word widespread is right, but like pain can be so different on each person with SI joint pain. So this picture is some common areas of SI joint pain. So you've got the iliohypogastric area, like in the abdomen. This can sometimes feel like something's wrong with your viscera. Like some people think that they're having appendicitis, but it's SI joint pain. It can be suprapubic region or groin region. So you can think that you have like something going on, you know, urogenitally. You can have groin pain, like a labral tear type symptom. I've had many athletes been told they have a labral tear based on their pain patterns and pain provocation tests, but you know, wasn't their labrum, it was their SI joint. You can have front of the thigh pain, like a quad, like hip flexor type of feeling of pain. You can have pain down the lower leg, so it's often mistaken for like sciatica. You can have pain into the foot. You could have pain in the buttocks itself. Like there's a lot of areas that you can have pain from SI joint pain generators because of all the nerves that innervate it, right? So no wonder it's such a difficult thing to diagnose and treat. In my observations at Movement Rev, I find that the hypermobility drives pain. Pain is often on the side that moves versus the hypomobile side. I would also say that it's rarely a true hypermobility, especially in the absence of a high velocity injury, pregnancy, postpartum, or like a true hypermobility disorder. Most of the time, it's from SI joint nerve irritation. From one side that's moving more because one side's not moving at all. And if we could get the side that's not moving at all to start moving a little bit, it takes the load off of this side and the nerves stop getting irritated, right? Pain on the hypomobile side is a little less common. I see it more with people who have arthritis, like diagnosed arthritis of the SI joint. They have bone spurs. And in fact, there's even a common diagnosis of obturator nerve entrapment causing some of those symptoms as well, as the obturator nerve gets entrapped by the bone spurs on the anterior side of the SI joint. That is typically involved with arthritis. Again, though, this pain pattern comes from the SI joint nerve irritation. Also very common, I'd say the most common form of people complaining of SI joint pain is people point right to the superior part of the iliac crest and they're like, I have pain right here, like right above their pant line. And oftentimes that's just a cluneal nerve entrapment, and that's actually from the lumbar spine, not the SI joint itself. So you can have a cluneal nerve entrapment superficially from the skin, from even the pants being too tight, or you can have cluneal nerve entrapment all the way up at the top of the lumbar spine as well. So not all pain around the SI joint is necessarily SI joint pain. Okay. So with the results cheat code, with this SI joint mobility locator test, we're not using this test to diagnose pain. We're using this test to figure out if there's a structural or strategic hypomobility that may be part of the pain pattern, right? Or may direct us to a driver of the pain. We're using it to determine if there's an influence from the viscera or the central nervous system or even the lower extremity. In the absence of visceral or central nervous system issues, if the hypomobile test directs us to the lower extremity, it may or may not be the joint itself. In the population I work with, it's usually driven from somewhere else, not the SI joint itself. It's still a strategic reflexive hypomobility or pain pattern. So we are not assessing or diagnosing a hypermobility or a pain generator, but I did give you the tools to look into it if you need to do that. But I find it less helpful to diagnose it when I'm just trying to make them feel better in the first place. So some scenarios, pain with hypomobility. Okay, we're going to ask the same question. Did the mobility change with the breath hold? If it did, then it's strategic, coming from the visceral or the central nervous system, right? I kind of move my chat box here. If it doesn't change with the breath hold, we're going to be directed to the lower extremity, peripheral nervous system, or the SI joint itself. If we have a structural hypomobility, we're going to ask or consider SI joint arthritis or fusion. We're going to think maybe there's a possibility for a false test, meaning if there was arthritis or a fusion, then that's no longer a good test for me because it doesn't have the ability to change. So I'm going to proceed with the rest of the LTAP if I have that skill set. Pain with mobility or hypermobility. When there's bilateral mobility and pain, I might decide to do the SI joint pain provocation test to validate that the pain generator is the SI joint itself. In that case, like if this is bilateral mobility, they have SI joint pain, and they fall into the category of pregnant, postpartum, high velocity accident, or high velocity injury, even in sport, or EDS or some sort of hypermobility disorder, then I actually will probably proceed with the rest of the LTAP because I'm going to assume that I can't get a good test out of the SI joint from those scenarios. And I want to see, is there a protection pattern somewhere else that could be referring to this area or not? Or I can just treat it, especially if they're coming in for SI joint pain, I can treat it however I've always treated it. When there's a unilateral mobility, we're back to the same scenario. Did the hypomobile side change with the breath hold? If it did, great. We know it's visceral central nervous system. If it didn't, great. We know it's lower extremity. Go there. See how it changes. So hopefully you see that it sort of like organizes your thoughts a little bit better around SI joint pain and what you can and cannot determine and help and potentially treat a little bit differently. So with that said, I know a few of you have already commented in the course that you're like seeing some amazing changes with your people and your clients are happy and like super pumped, and I love it. And so hopefully you're already seeing how this can start to give you some better results by knowing where to start. But how we get even better results is becoming more precise with both our assessment and our treatment. And just like we talked about when we were talking about the viscerosomatic reflexes, we become more precise when we have more information. And more information comes with doing the rest of the LTAP, right? Which is like, this test is really great and it's a quick, like, bucket, you know, like it can quickly put some people in buckets of what they need, visceral central nervous system, lower extremity, same side, or you're good to go. But if we can figure out for everybody that goes in the bucket of the visceral or central nervous system, if we could figure out what organ it is it the central nervous system, or is it the heart, or is it the lungs, or is it the small intestine, or is it the kidney? We can get way more specific with our treatment and have a better outcome. Same thing for the bucket of the lower extremity. Instead of just knowing that it's the same side lower extremity of the hypomobility, we can figure out where in the lower extremity. Is it in the thigh? Is it anterior, posterior, medial, lateral? Is it around the knee? Is it around the fibula? Is it around the foot? Like where to start in the lower extremity. We figure that out using pulses in the 5th test of the LTAP. So the whole point of the LTAP, the whole point of all of this is to narrow in our focus to figure out exactly where the patient is protecting. And the more information we have about the area of protection, the better and more precise the treatment can be. So as a reminder, this course, this free course, the results cheat code, was the first step of the LTAP, which is 5 different tests. So the 5 different tests starts with the SI joint mobility test. Then we go into central nervous system tension pattern, thoracic decompression and inhibition, the visceral inhibition test using manual muscle tests, neurovascular tests, inhibitions using pulse rate. So remember, when we're doing the whole LTAP, we're asking the body 3 questions about where to start. We're basically saying, are you protecting something that's important? If you are, what and where is it? And then also we're asking what the sequence of treatment is and when can I treat somewhere else, or when can I treat where I think or the patient thinks is necessary. So this is what the whole LTAP flow sheet sort of looks like. Each one of the colors is one of the different tests. But you see, just like we talked about even with just this results cheat code test, is like we're constantly like, do it, figure out where to start, do an orthopedic assessment, do the treatment, and then retest. Like we're always going through that retest. So I know it sounds like it can take forever, but it literally is quick. Like in the LTAP level 1 in-person course, I get people to do it in under 7 minutes. So it's very quick. It feels like long in your head because you're thinking so much about it. There's a lot of cognitive dissonance happening, but really in true practicalness, it's quick. It shouldn't take very long. So I always explain it to people, you know, so oftentimes athletes, when I work on them, they'll be like, you know, I work on them, I might not live in the same town as them, or they might be coming in to see me. And so they're like, can you write down everything that you did so I can give it to my therapist at the team or at my hometown? And I'm like, well, I could write it all down, But this is the thing. It's not what treatments I did, it's the sequence I did them in. So it's like a combination lock. I can give you the 5 numbers of the combination lock, but if I can't give you the sequence of those numbers, it's not going to have the same effect. You're not going to open the lock up. And this is how our bodies are. I can tell you the treatments I did on someone, but the body has to tell us the sequence. It's the sequence, those layers of protection that we're unpeeling. This is where the results happen, is this following the wisdom of the body on how to sort of unweave it all, unlock it all. It's not the treatment itself. It's the pattern. So that's why I want to invite you to join me for the whole LTAP Level 1 course. So hopefully these 4 days have been a great, a great taster of it for you. So you can kind of see sort of the overarching methods and thought processes and see how osteopathic principles can influence orthopedic tests. But there's so much more to learn, right? And so much more anatomy to learn too of the visceral organs and the central nervous system and the peripheral nerves. There's just so much more. So in the Level 1 course, both in the online course and the in-person course, we're going with the core beliefs that the SI joint connects everything, just like, right? It starts with this. The SI joint connects everything. Where you start matters, and the sequence you treat matters, and specificity and precision matters. So specificity and precision with assessment and with treatment. Even though treatment techniques can be pretty general, the more precise we get on where, the better the effect. In the online course, there's pre-recorded tutorials of assessments, anatomy, treatments, and cases, just like this week has been. Each week is focused on one test, and then we put it all together. So the first week we'll start on the SI joint test. You'll learn both of those tests, not just this one. You'll learn the supine test as well. And then the next week will be the central nervous system test, and the third week, the thoracic, and the fourth week, the abdominal and pelvic, and the sixth week is putting it all together and a little bit about what to do in the upper extremity. And then it includes more treatment options if you're looking for that. There's weekly live Zoom calls. So they're Wednesdays at 12 p.m. Pacific. Of course, they'll be recorded. It is literally impossible for me to make everyone's time zone work. So I just got to do it for me and my schedule. But you also have Voxer access to me. So Voxer is like a messaging app. It's almost, it's like basically being able to text me at any time. It's a walkie-talkie app, so you can talk, leave me voice messages, you can share video, pictures, that kind of thing. So it's like having me in your back pocket. You can ask me questions about your cases. You can send me videos of you doing the tests and get feedback on them. It's as close as you can get to being with me in person. As a bonus, when you enroll in the next 5 days, you get lifetime access to, well, actually, when you enroll in the LTAP Level 1, you get lifetime access to the results cheat code online course. When you enroll in the next 5 days, you also get a discount. So I'm offering $100 off to everybody that has participated in this year's results cheat code. And there's payment plans that are available as well. Then there's also in-person courses. So there's 2 in-person courses coming up this year. I just had one 2 weeks ago in Arizona. It sold out really quickly. So I expect these 2 courses to sell out as well. So there's a June course in Washington, D.C. It's a 2-day course. It's June 15th and 16th. It's from 9 to 6 on Saturday and 9 to 4 on Sunday. It's same content online. I do give a little bit extra in the handouts for the course, but the real extra you get is an in-person experience. We have real-time treatment ideas and examples. I do sometimes demonstrate an extra spine assessment for central nervous system tension. Most important, you get to connect with like-minded individuals, and also irreplaceable, you get feedback on your hands-on skills. You can get my hands on you, my teaching assistant's hands on you, and then your hands on us, so we can give you feedback on pressure and those kind of things too. You also get lifetime access to the results cheat code with this. And right now it is still on early bird, and there are payment plans available. There's also a course in November in San Diego, and they're both about half full. So we have about 10 spots left in the Washington course. Oh, I have that backwards. 9 spots left in the Washington course and 10 spots left in the San Diego course in November. So filling up fast. So as a bonus to the people who participate in the results cheat code, if you bundle the online course and the in-person course, which is the complete bundle, you get $300 off. So the complete bundle. And this basically also makes you eligible to sit for the LTAP certification that I'm rolling out at the end of the year. So I'm going to have an LTAP certification so that I can do a directory on my website, because I get so many people who reach out to me and want to find practitioners who are practicing the same way as I am and seeing the body in this way. So I want to be able to create a group of people that I can refer to. And so that is why I'm doing the certification. You'll also get, once you attend the, if you attend the in-person course, you also get invited to exclusive professional development opportunities with the mentorship alumni, and get a discount on the mentorship course and calls in the future. So this kind of breaks it down. $100 off the online course, $300 off the bundle. The coupon code is results 2024. The website to access that, because it's not open to the online course is not open to the public yet. So this is a secret website. I'll drop it in the chat. The coupon expires so funny. The coupon, I do not know why it's not letting me share in the chat. The coupon expires Monday at 11:59 p.m. Oh my gosh, so weird. I'm not sure why I can't share in my chat. That is the strangest thing ever, but I'll email it out to you after the call tonight anyways, so wouldn't worry about it. Yes, I need it. I love that. So couple things. One person asked, will the certification count towards CEUs? So depends on what CEUs you're looking for. So right now, the in-person courses are pending for CEUs for the June and November courses, both for BOC CEUs, so athletic training, and physical therapy. Doing physical therapy CEUs for Kentucky, because that's one of the states that is reciprocal with other states. So possibly, I will not know, probably BOC, I will not know until middle of May. I think I might hear back from the PT a little bit sooner, but as soon as I know that, I'll announce it. The certification, though, the extra work you do for the certification, which is going to be a test and 3 case studies, that will not be additional CEUs. So the CEUs that you get will be just for the in-person course, but both the online course and the in-person course, you can always audit for CEUs too. So NSCA, they're pretty strict, so it would be non-approved NSCA, so you would have to make sure. What else was I going to say that? I don't think so. Oh, remember the check-in. Oh, see, this is so weird that I can't use I can't chat. This has never happened to me before. I will email this out, but make sure that you click on this link in the notes for the check-in for the live call. And be eligible to win the raffle prizes. Oh, that's the other thing I wanted to make sure I told you. Free access to this course ends Sunday at 11:59 p.m. Pacific time. So if you're behind, you have a few extra days to catch up, but no, it goes away after that unless you enroll in the LTAP Level 1 courses, then you get free access to it forever. So that's it. I think that's everything. So obviously, if you guys have more questions, I'll answer the questions. That's it for the formal slideshow. Let me see what I missed here. The weekly Zoom calls each week, I allow 90 minutes for them, but somewhere between 60 and 90 minutes typically. Christina said, LTAP Level 1 question. Since my business is pretty much 98% virtual now, can the rest of the LTAP be applicable test-wise? Yes. I did love this G code because it can do virtually. Yes, I used the whole LTAP virtually. And many of the people who've gone through it do too and get good results. Empowering athletes asked oh, I answered that, how long the calls are. Marjorie, this was great. I'm looking forward to seeing more of you when the 6th course begins. You're welcome. Thanks for being part of it and the in-person. Hannah, I'm really hoping I can go to the June course. I hope you can too. Kayla, if you do the online and in-person classes separately, will you still be eligible? Yes, if you've already done the online course, if you've already done the in-person course, that's fine. You can do them separately. It doesn't have to be in the bundle. The bundle just saves you money. LTAP Level 1 question. Oh, I already asked. I already answered that from Christina. Yep, great. Cool. Anybody else have questions? Questions on the content from today or from the last 4 days? Questions on the LTAP? Danielle, hoping to make it to San Diego. Will the link to sign up be in Teachable? Yep, and I'll email it out as well. I'll email all the links and I will put them in Teachable. So you'll have all the information you need. Sorry that I can't drop things in the chat all of a sudden. It's very strange. Oh, maybe I can do it this way. Oh, there you go. Figured out a different way. I'll put in the link to the check-in form as well for you all. And there we go. So funny. I think it did that because I don't know, I sent the form at the beginning and I don't know why it changed. Zoom's weird sometimes. Very strange. Well, thank you for being here. I really appreciate it. All good questions. Oh, here's another question from Allison. Is there a significance in starting on the right side for the visceral focus mobility? You always seem to start there on the right side. Didn't know if there was a systemic reason. No, not necessarily. Just liver comes up a lot on people, so it's a easy target. But no, you can start on the left if you want. Technically, the right phrenic nerve, depending on what anatomy research you're reading, the right phrenic nerve may have a little bit more of a role in sensory to the upper part of the gut. So that's why I tend to go right accessory nerve for the treatment, but also you could do both sides. It's not that it won't matter. Because left phrenic nerve too goes to the thorax. So, you could do both sides. You could also, sometimes you can do one side and then retest and see how it tests and then do the other side and retest. So you can get really specific on if there was a side that mattered. But, general works really well sometimes too. Yeah, you're welcome. Thank you all for being here. You've been a great group. I'll continue to answer questions and comments in the course up until the course closes, and then the raffle prizes will be announced on Monday. So look for that in your email. Katie asks, is there a way to share the videos of the exercises and self-treatment with my patients for HEP? Some of them might be on my YouTube, but I can't guarantee all of them. So I would, and then also in my experience, my patients prefer videos coming directly from me. So as opposed to me linking somebody else's random thing. So I would recommend just filming them for your person, or use your phone to film them when they're doing it in front of you when you teach it to them, and then you send them the video of them doing it. So that's always a good way to do it too. So while you have it, film the videos. Yeah, April said I film my clients. Yes, you all are welcome. Thank you for being here. Okay, have a great night. Have a great rest of the week. Look out for the emails from me, and we'll talk soon.